Hello and welcome to this video on pleural effusion. Pleural effusion refers to fluid in the pleural cavity. This might be because of a transudative process where there is extravasation of fluid from the intravascular compartment due to an imbalance between the hydrostatic pressure and the oncotic pressure. Or it might be an exudative pleural effusion, which is a protein-rich fluid usually occurring due to increased capillary permeability. So the important causes of a transudative pleural effusion are congestive cardiac failure, nephrotic syndrome, and cirrhosis of liver. Important causes of exudative pleural effusion are infective conditions like tuberculosis, pneumonia, and empyema, malignancy, which may be a primary malignancy of the pleura, which is known as mesothelioma, carcinoma of the lung, or metastasis from a distal organ, uremia, and other inflammatory conditions like rheumatoid arthritis and systemic lupus erythematosus. There might be other types of fluid in the pleural cavity also. For example, a blockage in the lymphatic drainage may lead to accumulation of lymphatic fluid, which is milky white in color, and the condition is known as chylothorax. Similarly, blood in the pleural cavity is known as hemothorax. The patient may remain asymptomatic for a long time, or they may present with shortness of breath, which is often insidious in onset and worse on exertion. The patient may also complain of cough. In the initial phases of an exudative pleural effusion, the patient may experience pleuritic chest pain as the two surfaces of the pleura rub against each other during respiration. This usually subsides as more fluid accumulates in the pleural cavity and the two surfaces get separated from each other. Sometimes the patient may complain of a feeling of heaviness on the affected side. The patient usually prefers to lie on the affected side. On examination, there may be reduced chest expansion evident both on inspection and palpation. On percussion, there is typically stony dullness over the affected area. Both vocal fremitus and vocal resonance are reduced over the affected area. And on auscultation, breath sounds may be absent or reduced over the affected area. So to summarize, on clinical examination, there is reduced chest expansion, dullness to percussion, reduced vocal fremitus and vocal resonance, and absent or reduced breath sounds over the affected area. Investigation has two important components: imaging and examination of the pleural fluid. Chest X-ray is the most commonly employed method of imaging, and ultrasound is more sensitive in picking up pleural effusion. CT scans are done in the case of exudative pleural effusion when malignancy is suspected. This is a chest X-ray showing a large pleural effusion on the left side. So you can appreciate a homogeneous looking opacity on the left side, which has completely blunted the costophrenic angle, which is the angle between the diaphragm and the costal margin. The upper margin of the opacity is concave with the concavity facing upwards. Laterally, you can see the margin of the opacity tracking upwards along the costal margin. Pleural fluid aspiration is done for examination of the pleural fluid. These days, this is usually done under ultrasound guidance, as this is much safer compared to a blind procedure. The fluid should be inspected with naked eyes. Most of the times, it is straw colored in appearance and a clear fluid. However, in the case of infection, it may look turbid or it may be frank pus in the case of empyema. Blood-stained pleural fluid is a feature of malignant pleural effusion. The sample should be sent to the laboratory and the following investigations are usually done. Protein and LDH level help us to decide whether this is an exudate or a transudate. The glucose level is usually suppressed in inflammatory conditions. White blood count may be raised if this is an infection, for example, due to pneumonia. Frank pus may be seen in the case of empyema. Similarly, the fluid should also be examined for the presence of any malignant cytology. Microbiological examinations include gram stain culture, Zn staining, and culture for tuberculosis. These are the criteria for the pleural fluid to be called an exudate. A pleural fluid protein to serum protein ratio of more than 0.5, pleural fluid LDH to serum LDH ratio of more than 0.6, or a pleural fluid LDH level of more than two-thirds of the upper limit of the normal value for serum LDH. The presence of any one of these three criteria is sufficient for the pleural fluid to be labeled as an exudate. When none of these three criteria are present, the pleural fluid is a transudate. Now, depending on whether the fluid is an exudate or a transudate, further investigations can be done as we know the important causes of transudative and exudative pleural effusions respectively. The treatment of pleural effusion is essentially that of the underlying cause. However, if the pleural effusion on its own leads to significant symptoms and is troublesome for the patient, aspiration, a therapeutic aspiration may be done where up to 1.5 liters of the pleural fluid may be drained in one sitting. If there is a large amount of pleural fluid or if it recollects very quickly, then a chest drain should be inserted for complete drainage of the pleural fluid. Occasionally, when there is recurrent pleural effusion and the cause cannot be easily addressed, talc or drugs like bleomycin may be injected in the pleural cavity, which leads to an inflammatory reaction leading to fibrosis and obliteration of the pleural cavity. So these are some of the methods to address pleural effusion. However, it is important to find the underlying cause and treat it if possible. It's worthwhile mentioning here that in the case of empyema thoracis, when there is pus, again we need the pus to be drained out in addition to appropriate antibiotics. Thank you very much.